Okay, we'll call the meeting to order, and I'll just announce the substitutes first. Substituting for Lake Millville, we have Minister Byrne will be here. He's not here yet. Substituting for Mount Pearl North is Harbour Grace Portagrave. Substituting for Topsail Paradise is Conception Bay South. And substituting for Waterford Valley is St. George's Humber. So typically we take a break about halfway through. So we'll see where we're to with the subheads around 7:30. I just want to remind you that sometimes they leave the lights on upstairs, and that's okay, so we can go back and forth. But if they don't have your light on, and if you know how to say your name, just wave also so that they can see who's speaking. Please don't make any adjustments to the chairs, and we have water coolers in the ends of the room, and I know there are glasses over here on this side if you want some water. So I will first ask the committee members and the substitutes to introduce themselves, and I will go over to departmental officials. We'll start here with Conception Bay South.
Barry Penton, MHA for Conception Bay South.
I'm Darrell Hines. I'm the Director of Research and Legislative Affairs for the Opposition Office.
Chris Tibbs, MHA for Grand Falls, Windsor Buckets.
Jim Din, MHA for St. John's Centre.
Stephen Kent, Research Assistant for the Third Party Office.
Pam Parsons, MHA for Harbour Grace Portagrave.
Scott Reed, MHA, St. George's Humber.
Jerry Byrne from the beautiful and historic district of Corner Brook.
Jim Locke, Research Coordinator for Government Members Office.
Did you introduce yourself? Yes. Did you? Yes? Did you introduce yourself? Yes? You did? Okay. Minister Studley.
Thank you, Sarah Studley, Acting Minister of Mental Health and Addictions.
John Haggie, Acting Minister of Health and Community Services.
John McGraw, Deputy Minister.
Chad Antle, Departmental Controller.
Alicia Chenard, Executive Assistant to Minister Haggie.
Bradley George, Executive Assistant, Mental Health Addictions.
Patrick Morsi, ADM Corporate Services.
Just wave there.
Janine Harrod, ADM Regional Services.
Brian Scott, Director of Communications.
I don't think the lights are coming on.
No. Janine Harrod, ADM for Regional Services.
Brian Scott, Director of Communications.
Jillian Sweeney, Assistant Deputy Minister of Population Health and Wellbeing.
And I'm Greg Clark, ADM of Professional Services and Workforce Planning.
Okay, thank you very much. I now ask the committee has a copy of the minutes from the previous meeting, and I now ask for a mover to the minutes. Minister for Portagrave. Okay, thank you very much. All those in favor? Aye. All those against? Carried. We will now proceed with the estimates review process. Once I ask the clerk to call the first subhead grouping for the head of expenditures, I will then ask each minister to proceed. Each minister gets 15 minutes, yes, clerk? Yes, so each minister will get 15 minutes, if they so desire, for opening remarks. I ask the clerk to call the first subhead.
1.1.01 to 1.2.02 inclusive.
1.1.01 to 1.2.02 inclusive, executive and support services. Minister Studley, would you like to start?
Thank you very much, Chair. So I do have a few opening remarks. So Budget 2025-2026 continues to strengthen commitments made under Towards Recovery and our two provincial action plans, the Alcohol Action Plan and the Our Path of Resilience. This includes a special focus on the opening of the new Adult Mental Health and Addiction Centre and furthering support for the treatment of substance use disorder for residents of Newfoundland and Labrador. One of the recommendations achieved during Towards Recovery was an increase in provincial mental health and addiction spending from approximately 5.7% of the total annual healthcare budget to 9% to better align with the recommended national average. This increase was sustained in 2023-2024, when 9.4% of the mental health and addiction spending came from the overall healthcare budget for Newfoundland and Labrador. This is higher than the Canadian average, which is 6.3%, and the highest percentage in the Atlantic region, which is from the Canadian Mental Health Association in 2024. Spending on mental health and addiction services and supports is having positive results. Budget 2025 will continue to build on this through the following investments: $1.8 million to expand rapid access to substance use treatment and withdrawal management services within the existing opioid dependence treatment hubs in all Newfoundland Labrador Health Services zones, as well as to establish a new treatment hub in the eastern rural zone. Over $600,000 to enhance access to naloxone kits province-wide with the goal of reducing opioid-related overdose deaths. Nearly $10 million for community-based step-down facilities to support individuals who do not require hospitalization but need specialized supports to successfully transition to community. $1.17 million to establish a 10-bed substance use adult treatment center in Labrador, supporting access to substance use and addictions inpatient treatment closer to home. $1.2 million to increase access to medical withdrawal management services at the Recovery Centre in St. John's, the only dedicated withdrawal management facility in the province, and $566,500 to expand access to inpatient treatment beds at Humberwood, building on its highly successful model, and $2 million to plan and implement sober living recovery homes as an intermediary step between substance use inpatient treatment and the transition to home. And so other highlights of Budget 2025 includes continuing support for the two provincial action plans, the Alcohol Action Plan and Our Path of Resilience, ongoing access to a suite of free e-mental health programs available on Bridge the Gap, supporting operations at the new Adult Mental Health and Addiction Centre, which opened yesterday and represents a new era in mental health and addiction service delivery in Newfoundland and Labrador. Implementing a customized public awareness campaign to improve awareness of the mental health and addiction services available in Newfoundland and Labrador and how to access them. We're very pleased with the progress to date in transforming the provincial mental health and addiction system to one that is person-centered and recovery-focused, and will continue to work with our many partners in government, Newfoundland Labrador Health Services, the community, and people with lived and living experience to develop innovative solutions to enhance access to appropriate, timely, and compassionate support for all Newfoundlanders and Labradorians. I do want to add that I think it's a super privilege to be Acting Minister of Mental Health and Addictions for the opening of the Adult Mental Health and Addiction Centre. I've had a tour of it. I know some others here have. It's an incredible facility. I also toured the former Waterford Hospital, which is no longer, seeing new patients now, and all the patients have been successfully transferred to the new Adult Mental Health and Addiction Centre, and it was a very stark contrast to see the old and the new. The old was dingy, grungy. There was a patient in kind of an outdoor area, which, as I was going through, and I just can't even fathom the experience from a mental health perspective. getting treatment in that former facility and now contrasted with the experience in the new facility. There is a virtual tour online now, which if you're curious, I'd recommend everyone check out. Will give you a sense of what I do think that in this instance, the physical infrastructure will have a significant impact on patient outcomes and the mental health of Newfoundlanders and Labradorians. So saying that, thank you very much. I'd like to pass it over to Minister Haggie.
Minister Haggie.
Thank you very much, Chair, and great to be here for what is my 8th budget for Health and Community Services. I hadn't quite anticipated number 8, but things happen. This year, our budget, comparing like with like, is in the estimates book vote will be $4.7 billion. Last year was $4.5 billion. And if you look at that compared with the budget from 2020, you're looking at a 42% increase. That shows a commitment on behalf of this government particularly with the emphasis after COVID and the health accord. We've made record investments in healthcare, and we're actually seeing real and measurable results. These don't appear in the lines of dry numbers that you see in the Heads of Estimates book, but I think there's a story to be told of what last year's money has brought. There are 75,000 people now in the province connected to family care teams, structures that didn't exist a couple of years ago. And of the people who are not yet connected but are listed with Patient Connect, there are 18,000 people in there that have accessed care virtually. For those listeners at home, if you haven't got a family doctor and are not registered, I would encourage you to do so, because that will enable you then to access virtual care through Teladoc, which is a quantum improvement over other virtual methods of care. Recruitment and retention has been highlighted in this chamber, and it's a major challenge for everybody. I would argue it's a major challenge across the globe, and it's certainly a major challenge in Canada. In the last 2 years, however, we've recruited over 140 doctors with our endeavours and incentives, and more than 1,100, I think it's 1,133 nurses, of whom 760 were RNs. In October 2022, there were 752 RN vacancies. Today, that number is 300. That's a huge progress in just 2 years. In terms of access to surgeries, there has been an emphasis on improving and increasing access to surgical procedures. The ones that are measured nationally, our figures are showing a significant benefit. We've got travelling orthopaedic programs for surgery for joint replacements in St Anthony and Carbonear. We've got same-day hip replacements and knee replacements in St Clair's and Corner Brook, and a short-stay orthopaedic pilot in Gander working on developing those short-stay beds there too. And we've expanded surgical capacity across the province. There's 2,200 or more orthopaedic surgeries in 23 to 24, which is a 29% increase. And that's from pre-pandemic levels, not just picking up after the pandemic. This is pre-pandemic comparison. And we continue to build on that process. With our approach to cataracts, between April of 24 and January of 25, 10,834 cataract procedures. That's an increase of just under 16%. Again, showing the success of the programs. So building on that, Budget 25 has further investment, another $35 million to bolster, enlarge the family care teams that exist, and also to open new ones. Continued investment of $10 million again for recruitment and retention, bearing in mind the successes of the last 2 years of investment. $4.2 million to expand undergraduate medical education seats for Newfoundland and Labrador students here in Memorial. And $10 million in digital health. So that includes both virtual care and access for patients to their own record and information through My Health NL, And I think there are around 115 to 120,000 people using that service to access their own information. We're trying, and I think we're continuing to succeed in making it easier for people to access their services, and this can be done from home. We heard about IVF. We had a program that was put in place as a bridging maneuver. We've increased that level of support, and now we're on the cusp of having a larger fertility service and clinic in the province. There was one already, and that's going to be enlarged and built upon. In terms of other elements within healthcare, pharmaceuticals are always a pressure point. This year, the extra on the budget is $17 million. That is the highest increase I've ever seen in all my time in health, version 1 and 2. And 18 new drug therapies will be bought for that, for the provincial drug program, a mix of cancer and non-cancer drugs. We're investing in ambulance services, urgent care centres, and a new ambulatory care hub in St John's. In Corner Brook, there's $13.6 million for a new community care centre, which is transitioning available space to 15 transitional care beds and 30 long-term care beds to ease their challenge with alternate level of care patients in Western. Other initiatives in the budget speech include expanding cardiac catheterization services with a 4th lab, a new CT service for the Dr. Charles Legros Health Centre in Port aux Basques, which is not there at the moment, the CT that is, and continued investment in stroke care, building on the provincial stroke program and Dr. Brown's pioneering work in this province in bringing EVT as a real and tangible treatment, which will be of significant benefit to an important group of individuals who would otherwise end up permanently disabled. And continuous glucose monitoring for our type 1 diabetics in the insulin pump program. Other concerns we hear are around wait times and backlogs. There's $10 million in budget 25 to reducing delays. That is expanding MR and CT services, and details include extra machines, extra hours, and faster software that will enable more scans to be done in a working day. Increasing capacity again for more joint replacements, a dedicated hip fracture unit for St. Clair's for rehabilitation for a significant burden on the acute health services, and this will help ease that and move these patients through in a more appropriate way. Adding 5 orthopaedic surgery beds, and across the province, both here in St. John's and on the West Coast, expanding PET CT services. In addition to that, the focus again from Health Accord has been around preventative cancer care. So there's $4 million more this year. HPV testing for cervical cancer and the like, a new lung cancer screening program, and expanding the lower age limit of breast cancer screening to women between 40 and 49. Mental health and addictions, my colleague here has alluded to, but they remain an integral part of healthcare in line with towards recovery and keeping any suggestion of a separation of some kind of difference between mental versus physical health and keeping them welded together. I think that's important from a stigma point of view. I think some of the successes we're seeing in mental health in terms of demand, paradoxically, come from this destigmatization, which has been a focus of government for some years. One of the key background pieces, which everyone I think takes for granted, but nobody really acknowledges in many respects, is health information. Our health information systems are outdated, and there are multiple legacy systems that not only don't talk to each other, but were deliberately designed not to talk to each other, and we're fixing that. And there's another $140 million allocated in this year's budget to roll out better information management, which will benefit patients, it will benefit administrators of the system, it will help the department in its prioritization, it will enable patients to directly access their own information without gatekeepers, because after all, these are the patient's charts. We the system are simply custodians. And overall, will improve the front end of healthcare in a way I think people really don't realize yet. Seniors are a significant portion of this province. We have one of the most rapidly aging and significantly aged provinces. We've got $10 million for seniors' health and well-being through a variety of grants. The other piece, and I can get into this in some detail, is around, because I see my time is running low, is financial responsibility and accountability. It is important that this money, which is a huge portion of the provincial budget, is spent efficiently, effectively, accountably and responsibly. And we need to build tools to do that because, again, we have legacy systems at the back office as well. I'll go quiet.
Thank you, Minister. The member for Conception Bay South.
Thank you, Chair. On those sections, I haven't got questions per se, but I got general questions, and I hope that's fine to start with. Minister, the Topsail Road Urgent Care Centre, where are we to with that? What's the time frames and staffing? What's the status with that, I guess?
Minister Haggie.
Thank you very much. I will defer to Mr. McGrath here about the Topsail Road Health Centre.
Deputy Minister McGrath.
John McGrath, sorry. Deputy Minister, trying not to joke. There is money appropriated in this year's budget for the Urgent Care Centre. For an exact date on when it's going to open, I'm going to look at Patrick to see if he can get that. There is money for operations, as you alluded to, for hiring staff. That did come in through Budget 2025. And like I said, there is an appropriation this year for it. For a date for when we're going to...
Patrick Morris. Okay, go ahead.
Oh, sorry, it's the fall is what we're projecting.
The fall to open? Is that what you're saying? The fall? Fall opening, yeah. The fall?
I think that's
fall?
What... Yeah, this... Yeah.
And do you anticipate any problem with staffing? Because I know that's an issue.
Minister Haggie.
The short answer is we are working on staffing, and in terms of problems, we'll know when we go out and put the posts out there. We have a wealth of incentives. They have, by and large, been very successful, and the challenge for recruitment now is much more rural than it ever was. The urban areas here are relatively well looked after and relatively attractive because of their other surrounding appeals. As I've said in other fora, you may recruit a doctor, but you attract a family.
Minister, Change Healthcare, the Integrated Capacity Management System, that was a $35 million deal. Whatever happened, whatever became of that?
It's alive and well. It's fully implemented in Eastern Rural. It is implemented at the Janeway. I think there's a rollout in place in the remaining areas of the Health Science Centre. It is delayed in Western for reasons which I can't quite remember, but I'm sure my colleague to my left would be able to explain that. And it's being rolled out in across Central. This is going to be a key piece in matching acuity of patients to staff and using our staff responsibly and appropriately. So it's alive and well, and it's there. I would have liked to have seen it go out a bit quicker, but, you know, there's always a little stumble here and there.
How much savings has been found to date?
Sorry, from ICM?
Yes.
I don't have that figure. We can look and see if we can find it for you.
Is this a US-based company?
My recollection is it has US affiliations, yes. This was awarded some years ago.
And how long is that contract for?
2.
Deputy Minister McGrath.
John McGrath. I could certainly get that information for you.
Thank you, Chair. Respectfully, Mr. McGrath, we had a list of questions from last year's estimates, and we never did get any answers, not one. So that was something that was highlighted along the way. And actually, I spoke about this issue last year at estimates, and we were supposed to get an update that we never received, so I guess we'll, yeah, you'll, was it, live in hope and die in despair, but anyway, hopefully this time I'll get some information. Minister, this is a question come up in the House Assembly recently between myself and you, and U.S. contracts. So has there been any contracts cancelled with U.S.-based companies?
The direction was given to look at all our contracts and how these might be affected by U.S. companies. The challenge is that a lot of our sourcing is done through a group called HealthPro, which we're a member of. So we actually benefit from group purchase prices. So it's not quite as simple as that. To disentangle that is a work in progress. I am not aware of any contracts that have been cancelled. I am aware of one that has not been awarded because of the possibility of it going to a US company. Having said that, the healthcare market is troubled, if you want to use that word, by the fact that it is very, very dependent on the US suppliers. There are things that you can only get from the US. I mean, I think if you were to cancel all US contracts, for example, we would have no masks. We would have an inability to do TAVI. A lot of interventional radiology would cease completely because there are no readily available alternatives. So at the moment, you either deal with the devil or you don't deal at all.
Minister, Teladoc, isn't that an American company?
Our contract is with Teladoc Canada. It's incorporated internationally in Spain.
But there are U.S. doctors employed by Teladoc to deal with residents of Newfoundland, correct?
No, they're all Canadian licensed.
They're all Canadian licensed?
All Canadian licensed.
So what's the status? What's the numbers with that? Do you have any data on how many people they see or what they're...
We can certainly get that for you.
And the usage data? Do you have like the usage? How many people are using Teladoc? Like, do you have any numbers or any notes?
The only number I've got at the moment is 18,000 had virtual consultations. Whether those were all Teladoc or whether those were virtual in a different way, because virtual encompasses services provided through the NLHS as well. We can certainly get that breakdown of data for you.
And the same thing applies with the cost per call, like first year MCP. Should be able to get a quick breakdown through MCP, how many people are actually, the cost of actually, for Teladoc,
well,
for MCP billing?
Teladoc is contracted. MCP is fee-for-service, and the claims are remitted on a fortnightly basis.
But there has to be some way to figure out the cost per call.
Oh, yeah, we can do it. I'm just saying that they go through different mechanisms. You said it was all MCP, and that's not strictly accurate.
Yeah, that's fine. Minister, why haven't we signed on to the pharmacare, the National Pharmacare Program yet?
There is no federal government to sign on with, and the money ran out before the election. So as soon as the government is out of caretaker and the money is restored, we're ready to roll.
So it's just a matter of timing with the election, the federal election?
It's out of our control. This is a federal issue.
Okay. The National Dental Program, has there been any savings seen provincially for that program?
There has been a reduction under the heads when we get to dental services. It would be easier for me to do that as a head. If you want to do it now, I can look. Which would you prefer?
That's fine. We can do it then.
Okay.
Cornerbrook Cancer Centre. What's the update on that one?
There is a recruitment underway. And pending the recruitment of docs dedicated to that unit, there are discussions with the oncology team through what was Eastern Health and what's now NLHS to see if there can be some kind of provision of service either remotely or on a visiting basis until such time, so we can get the service off the ground and get it provided.
So what staffing is not, like what positions are not filled out there right now? What's the biggest gap?
I do believe they've got a medical physicist. I think they're shy of one, and there's some radiation techs that need to be hired. As to the exact complement of physicians that are out there, maybe ADM Clark would be in a position to answer that better than I.
ADM clerk? ADM clerk. Yep.
Greg Clark, Minister, I can't put my finger on the number of physicians that are required right now in Cancer Care Western, but I can say that we're hiring a dosimetrist and radiation therapist, as the Minister pointed out.
Member for Conception-Based South?
This one's probably directed more to Minister Studley. The new mental health addiction centre, the 10 community beds they're supposed to be located around outside the hospital. Where are they, or are they in the works, or I guess what's the status on those?
Mr. Studley?
Thank you for the question. Pass it to John or Jillian. Best. Okay.
Jillian? Jillian Sweeney?
Jillian Sweeney, ADM. Currently, there are a number of initiatives in place to support patients with mental health and addictions issues in the community. So, for example, the patients that were in more of the longer-term care beds at the Waterford, they were all placed prior to the move, and we are scaling up community resources to support people that are in the community in advance of the downtown center that will be built in the coming years.
So what precisely does that mean, though, to the, so the scaling, I mean, it sounds like it's in the works, but right now today, is there any physical place where they are, or like those beds, or they just deal with it as when it's a need arises?
Minister Studley.
Thank you. I can give an answer, and Julia, you can supplement, please. I know that the team, and I've heard a lot about how the team are finding creative solutions for long-term residents who necessarily, who don't need to be in the Waterford, but for many reasons, or in the new adult mental health facility, for many reasons, unfortunately, historically, have been institutionalized and cannot live on their own. So I heard of one very innovative solution where 4 individuals were accommodated in a residence, and they have staff supporting them, but they're living independently and they're sharing cooking and cleaning and those types of life skills, whereas before they were living in the Waterford Hospital. So Jillian, I don't know if you wanted to add anything. So those are before now, currently, living independently. If Jillian wants to add.
Jillian Sweeney?
Thank you. Jillian Sweeney, ADM. Yes, there are patients that would be located in a number of different settings throughout the community.
I mean, basically, what you're referring to, I guess, it's yeah, I mean, there's group homes throughout the province, throughout St. John's. There's a lot of them in St. John's, actually, that deal with a lot of those individuals. And my mental health counsellor days, I'm well aware of a lot of where they're located to. So what Minister Studley just mentioned, I mean, that's not a new thing. That's been going on for a long time, and it's going to continue on, I guess, for eternity. So, but basically, I guess what I'm applying, I guess what I'm asking, it doesn't appear, as was in the original plan, that those 10 beds are actually physically there now. It's just a matter of it's as needed basis, trying to find solutions as they arise. It was basically, I guess that's the clearest from responses. That's my assertion from that one. So would that be correct?
Minister Studley?
So I guess if you're looking for a breakdown of the beds in the new adult mental health facility, we can certainly, I'd ask Jillian to give us a breakdown of that, please.
Jillian Sweeney?
Jillian Sweeney, ADM. So we currently have a total of 102 acute care beds that are located in the new MHAC that opened yesterday, and there are also 14 beds for acute care that are in the Health Sciences Center that remain open as well.
So, Minister, if you put 4 residents in a home, staffed, and supplied quality of life to them, which I think is wonderful, what's the associated cost figure with that? Do you have an idea of what the cost of that is?
Minister Studley?
We can certainly get that. I think those individuals were they were full-time, long-term residents of the former Waterford Hospital, and they did not need to be in the Waterford Hospital. So I just want to, the kudos to the staff for thinking about how they can really give more life to these individuals. And so I think that was the spirit in which that was derived from, rather than having these people be institutionalized and continuing to do that. I think they tried an innovative option which so far has really worked out for those individuals. So we can certainly get the cost, but I think it's cost plus the quality of life for those individuals, and then that's 4 beds in the new adult mental health facility that they're not living in unnecessarily.
Member's time has expired. Member for St. John's Centre.
Thank you, Chair. The National Pharmacare, the legislation was introduced in February 2024, and it was proclaimed in October 10th, on October 10th, 2024. That's about 6 months ago. I'm just wondering, what were the negotiations prior to then, or the discussions with the federal government from then until now to get onto the plan, prior to the election? What discussions were taking place?
Thank you. Yes, I mean the detail around those plans would be how it is that the federal government either wished to take over the funding of things we already fund through our own drug programs, or whether they wish to introduce something that was simply complementary and kind of reconcile it at the end. And that was also then around the range of products that would be covered. The general discussion was around the concept of diabetes medications, of which there are numerous, and also around family planning, again, of which there are numerous. And so those details were trying to align what the federal government's desires were with what the practicalities of our drug plan would be, and how that would affect the use of money, basically. We were at a stage where we had reached some level of agreement and were kind of not very far from finalising it, and then the feds announced there was no more money and they would come back later, and then went to the electorate instead. So we're in caretaker mode. That's where we're up to at the moment. We're ready to resume those, and the feeling from the actual individuals who were involved in the negotiations was that we were very near to being able to have documents that we could present to the provincial minister and the federal minister.
Thank you. Thank you. So I know Manitoba, BC, PEI, and Yukon have signed on. There's some indication that really that those who signed on, well, they made it in. Those who had signed on wouldn't be, would basically the door shut. So is that your understanding, or your understanding that that discussions will continue once the election is finished?
My understanding is the door is currently ajar, and depending on who wins and what happens, if according to what you hear in the media, one party were to be successful, this would continue, and according to what the interpretation of what's been said by the other, this is nowhere near as clear should they win. So, I mean, I wait to see what happens on the 28th, just like everybody else.
Thank you. Chair, I asked with regards to the old Waterford Hospital, the facility and the site, what are the plans for the old hospital for the site?
Minister Studley?
I'm going to boldly, so anyway, my understanding is that there are teams currently in there, and they will be moving out over the summer. And let's say by August, September, all staff should be out of the Waterford. And then my personal preference is that it is decommissioned.
So once it's decommissioned, what happens then?
I think that's above my pay grade, but that's an excellent question, and we will. I don't have an answer right now. No, we don't have an answer. No.
Minister Haggie?
I have experience with one decommissioned hospital building, which was tortuous, time-consuming, and stressful. I don't know that under normal circumstances, buildings like that would fall under the remit of TI. They are responsible for that kind of thing, unless there was a decision and some proposal came forward prior to that. But that's all in the future. So I think it's a matter of speculation as to what would happen if normal situation applies and the Waterford is decommissioned. That building then becomes the responsibility of TI to manage as a empty/derelict property.
The reason I ask is when I was first elected, one of the suggestions made with regards to the old Grace General Hospital was, at that time, to use it as some form of deeply affordable housing that would be operated by not-for-profits, a board of directors that would allow for either you could have shelters, dwellings, you could even rent some of the spaces to not-for-profits at the time. Speaking to the Minister of Transportation Infrastructure, he said that would have been an idea, 10 years ago, but it's gotten to the point where the only thing that you could do is tear it down. Now, I don't know what the state of the Waterford Hospital is, but there is an opportunity here because I assume this land and facility is owned by the province. So there's an opportunity here to see if indeed this can be converted into something along those lines, and B, if it's going to be demolished because it's beyond reclamation, then I would assume too there's the opportunity here to establish either a land trust or a land lease community, which then could be used for by organizations, not-for-profit, to build deeply affordable housing or cooperative housing along those lines. But there's, I guess what I would hope, and I would hope that if you're in your recommendations that the building not sit derelict, and if it's to be sold, that maybe not-for-profits could be given first right of refusal to purchase that land or lease that land over the length of time. But I think it would, rather than sell it off to a private developer or retain private for such things, if that helps. Anyway, that's just my thoughts there.
Chair?
Mr. Studley?
Thank you. I just want to say personally, I agree, and as Acting Minister of Housing, I would also, I will push for us to look at, how we could best use that land, and I agree with your suggestions. Thank you.
Thank you. Possible to have an update on the Personal Health Information Act, and when might we expect to see amendments presented in the House?
Minister Haggie?
Thank you. Yes, I kind of anticipated that this might have happened after I left because we had commissioned some work on that. I think the general view in the department is that time has slipped by and that there is a new process of consultation underway, and the results of that will inform a revision of FEA. There are several areas there that really kind of didn't exist when the original bill was drafted and now do, and how you best deal with those in that legislation, I think, will be an interesting discussion, and it may actually be that we're required to modify the bill and split it in some way. But those are questions that are active with our legislative team, and the answer is, stay tuned, but don't hold your breath just yet.
Thank you. The long-term care and personal care home program review was released in February. Can the department provide any details on plans to implement any of the 23 recommendations?
Mr. Haggie?
Certainly. From my point of view, I know that those recommendations have been taken to heart, and staff in the department are working on them. There are impacts from the Auditor General's report on personal care homes as well, and what we'd like to do is mix those in, as it were, and then start to act immediately on those that are pressing. There is, in relation to personal care homes, an action plan that is being developed as we speak, and I hope to have something of a draft to see within the next few weeks, with the aim of implementing that in the very near future. Obviously, we'll continue to work with the personal care home operators. We've been in discussions with them, and they have issues that they would like addressed. We're happy to chat with them about it, and we'll work together to make things better.
Thank you. Will the department provide an update specifically on recommendation number 7 of the long-term care review, which asks for support for allowing couples to remain living together in care?
That is a work that is underway. We're trying to craft a policy that is both humane and fair, and we hope to have something in the not too distant future.
Thank you. What is the ratio, I guess, of caregivers and to patients in long-term care and personal care homes?
I have to get those details for you. They are going to be the subject of a core staffing review. It's one of the sites that has been chosen. If you recall, there was discussions before COVID, in actual fact, with then President of the RNU, Debbie Forward. Since then, the new president wanted some amendments made to that, and as a result of that, the process has really only just started with going out to the market. In terms of specific ratios, care hours are calculated on a needs basis by patient assessments, usually prior to admission, and then staffing is built up to accommodate those care hours. In terms of how that is managed, the ICM, the member opposite, was talking about earlier on, allows not only to do that in a responsive and proactive way, but also to engage in some predictive modelling for clients to better utilise staff and better ensure their needs are met. If you're looking for current specific care ratios, it would be very much case dependent, but I can try and get you some breakdown if you can narrow it a little bit for me.
Okay, member's time has expired. Member for Conception Bay South.
Thank you, Chair. I'd like to just go back where we finished off before the break for my time expired last. It's on the mental health new facility. So back in 2016, I sat in on the tail end. Actually, I was late joining, but on the Towards Recovery All-Party Committee. And one of the recommendations in that report, and Minister Haggie was chair of the committee, one of our recommendations was to replace the Waterford Hospital. And if I'm not mistaken, I don't think I am, but part of that report was less beds, but bring it more to the communities, because we all agreed after we went around the province that people with mental health illnesses out in rural Newfoundland, far away from St. John's, out in the middle of the city is not the place from they should be getting well, mentally well, in their own communities. But it appears that there's not, those community beds are not in place everywhere. And because I know there's been some, I know the Nurses Union said it wasn't big enough and not enough inpatient beds, but I've even said to my own colleagues that that's part of Towards Recovery plan. But the part that seems to be missing, and you can correct me if I'm wrong, is the community beds. Throughout the province, really, I mentioned in the city, but throughout the province, that was the whole intention of, I think one example at the time we may have heard, and if you recall, that was someone up in the remote areas of Labrador. I believe we were up in Nain together. We were in Northern Peninsula. That is a real issue with mental illness. It's not like a broken hip or a medical illness where you go to the hospital and get well and you're out in 2 weeks. As we know, mental health is much more complex than that. So I guess where those beds to, or whatever became of that recommendation, or are they there that we aren't aware of, because we don't seem to be able to get any tracking on that.
Mr. Haggie?
Yeah. I think part of the problem is, and you're right, I remember those conversations, and that was and still remains the thrust of Towards Recovery. I can speak only by example, but some of those beds, they do exist. They're just not called community mental health beds. They're called something else. We have facilities in Gander, for example, where we have individuals with mental health and addiction problems, issues, in the community in supportive living. And I think supportive housing has become the phrase that instead of community beds as such. And I think it's just a change in semantics. So you can see these there. The community supports for these individuals have been put in place. There are ACT teams and FACT teams that weren't there before. There's a regional mental health and addictions team, for example, in Central, which wasn't there 3 years ago. So the supports are there, and the beds have been relabeled as something else, and maybe this is a change in language on the advice of Recovery Council and these kind of individuals. So I take your point. I think your better number to look at might be, people receiving community care rather than where they actually sleep, because the facts of the case are that may change from week to week or month to month, and the idea is at the end of the day, if you are entirely successful, you get people living as independently as they possibly can, and that could be like you and me, and we wouldn't appear as living in supported housing or community beds. But you're right, the whole premise of the mental health reframing was a hub and spoke system with care in the community nearest to home or a home-like environment.
Thank you. Thank you for that. I guess that goes a bit towards the stigma, which is another big issue from towards recovery. I guess Minister Studley or whatever, maybe I'll answer this one, still not related. Are there any beds in the new hostel being used now for overflow for the Mental Health and Addiction Centre?
Sorry, I do apologise. I missed that. So I'm not actually sure what the question was, whether it was directed to me or Minister Studley. I do apologise.
No problem. Are there any beds at the new hostel being used now for overflow for the new mental health and addictions facility? Which used to be the Agnes Cowan, was redone to be the new hostel.
Yeah, Agnes Cowan doesn't exist anymore.
No, it was previous. Now it's a hostel. It's been converted to a hostel.
Minister Studley?
No.
That was a quick one. Travel nurses, Minister. How many do we? What's our numbers on travel nurses now?
Travel
nurses. Travel nurses.
My God.
Minister
Sorry,
estimates don't end until 9 o'clock.
We were trying to answer your previous question.
Oh, yeah, but she said no, so I just moved on.
No, it's all right. I do apologise. This is the difficulty. I'm not used to having being a wingman.
I know.
So our reliance on travel nurses still exists. The issue is that until we get rid of those 300 vacancies for RNs, we will always be reliant on locums or casual nurses to some degree. Again, I caution that in Labrador, travel nurses have existed for 50 years. They have become an integral and integrated part of healthcare on the coast, and I wouldn't like them to be tarred with some inappropriate feelings or sentiment because of the term travel nurses. They have served a valuable role for years. We are down in our usage of travel nurses by 42%, and I would anticipate that as our recruitment and retention efforts continue, that percentage will gradually drop. What it will end up at, depending on the Labrador piece, I couldn't quite say yet, but we could certainly model that for you with time.
Thank you. Nurses Union want all nurse graduates hired in a floater pool. What's the problem with that idea?
We have a class of 246. 222 have signed on for full-time employment within the province. We're working on the other 24.
He says they recruited 11. So I'm trying to understand.
Okay. So that Minister. I'm trying to rationalize a question. It's an issue that we spoke about last week. It's the nurse vacancies. I know that Ms. Coffey has not been on the same page with you, and I guess I probably agreed with her because I think I was clearly stated that I trust the union, and if they got a membership base, that they got a better track of it than me or you or anyone else, or they should anyway. mean, we had 700 vacancies last year. Apparently we recruited 1,100, but we still got vacancies. So are they leaving the province? Are we getting, like, what, that, the rationale, we should be up surplus if that's the case. So what's going on? We're losing that percentage of nurses, which is like probably 30% or more of our nurses. Are they leaving the province, retiring, or what's the issue?
So that 1,133 is nurses generically. It's not specifically RNs. If you want to look at RNs and be a bit more focused over a 6-month period, I think actually maybe a 9-month period. I'd have to check the dates again now because I'm working from memory. But we recruited 399 RNs. We lost 199. The average age of retirement of an RN is 58, and if you look at the demographics of our workforce, there is a bulge around that age. So we know we're going to have retirements. On the basis of that 9-month aliquot, we are 50% ahead in terms of reducing the vacancy rate. 399 in, 199 out.
Another issue, I guess, these are all come back to me. I've talked about it many times, and this is probably a great opportunity to bring it up again. The Health Human Resource Plan. Is there any time frame, any updated time frame? Because I know it's been an issue that's, I know I've personally asked for it more times than I can remember or recall. I'm sure others have asked for it as well. Is there any time frames associated with that?
Yes, a very short one. Watch this space.
Watch this space. I've been watching this space, Minister. So do you have any idea, though, any reasonable, like, it's not hours?
Before the end of the school year.
Oh, well, that's not bad. So we can wait, we'll live in, yeah. Okay, we'll wait till June. Are there any long-term care beds closed in the province now due to shortage of staff?
I'm not aware of any, but Mr. McGrath?
Deputy Minister McGrath.
Yep, John McGrath. None are closed right now, I'm told, because of staffing.
None?
No.
Okay. And with all the beds in acute care that are filled with our alternate level of care patients, I mean, what's the plan? I know that in Corner Brook, there's some beds being, I know Dr. Parfrey actually made reference to that in the old Corner Brook Hospital are being utilized. But what is the overall plan to deal with that issue?
Minister Haggie.
Yeah, it is an issue that is not common to one particular location. Health Science Centre have, done remarkably well. Their ALC rate was in the 40% 2 years ago. It is now 9%. The challenge is to try and replicate some of that in other areas. Corner Brook, there is an opportunity to rebadge and repurpose the old Western Memorial, now the Corner Brook Community Centre. So there are what are called 15 transitional beds. These are a very important part of the system because they take frail, elderly, or people who need a little bit more time and rehabilitate them so that they don't actually have to go to long-term care and that they can be accommodated in maybe personal care homes or in the community, which is preferable in line with the sort of philosophy of aging at home and aging in place. In Central, for example, they were pioneers in rehabilitating people in long-term care itself and actually rehabilitating them to the point where they could go either to personal care homes or back into the community. So it was in part, philosophy change that long-term care is not where you actually have to go and die. You can go and progress in that sense and go home. But it is a challenge, and our aim is to have as many people in the community looked after at home as possible.
The member's time has expired. The member for St. John's Centre. Member for St. John's Centre.
Thank you, Chair. With regards to ratios, so I guess I'm looking at, if you look at the different levels of care, 1, 2, 3, whether it's at the a long-term care facility, Pleasant View Towers. I'm just trying to get in there, like on a typical floor, what would be the ratio right now for, let's say, I don't know, a level 3 facility, or what would the I'm just trying to get an idea of how many people would be staffed both daytime and at night. I've heard at Pleasant View Towers at one time that there is basically 3 people per floor, well, and one nurse who would go between 2 floors. So I'm just trying to get an idea of what is the ratio.
Mr. Haggie?
Yeah, thank you. I mean, I think the reason it's hard to answer sometimes is simply because patients' level of care in terms of where they end up is actually determined by the care they need. So number of care hours provided. I think the average for a level 3 patient in this province is around 3.9 hours of actual nursing care. In terms of the actual ratio, this in some respects will be informed going forward as to whether we got it right with the core staffing review I alluded to before. In terms of what the typical staffing for a long-term care unit would be, again, it depends. I mean, if you go to Lakeside, there's a special care unit, there's a protective care unit, and then there's kind of the regular floor. And each of those are staffed differently. And if I generalize for one, I'm wrong for the others, because it is somewhat more particular. If you want, I mean, maybe Dr. Parfrey could produce an average figure for what the staffing complement by day would be, for example, for a long-term care facility. I know the newer long-term care facilities, such as Pleasant View Towers and particularly Corner Brook, are staffed slightly differently. There are 15-bedded pods, as it were, of seniors, and the staffing is done on the basis of that. So, Pat, Dr. Parfrey, I don't know if you've got any numbers?
To answer that question, but I'm sure we can get the information that's going. Do you have information, Janine? Janine?
Janine Harrod?
Janine Harrod. So the number of hours required per resident per day is outlined based on levels of care, has been described. For level 1 and level 2, which is a resident who would receive care in a personal care home, the hours of care are 2 hours per day, and that would be 2 hours of direct care being provided. For level 2 enhanced care, which also occurs within a personal care home, the total number of hours per day is 3.5. And for level 3, the total number of hours of care for direct care per day is 3.9, as Minister stated.
Okay, here's where I'm going with it. And the question, I guess, is it enough? And I'm assuming in level 3, 2 hours per day. That's not a lot in some ways, depending if how in need the patient is. But I know we met many years ago when I was first elected with the group. They were promoting Lillian's Law, which was basically establishing a ratio, and I said at that time I think it was like 1 to 3 or something like that, especially in the of having enough, because we can talk about hours. I guess it comes down to, well, how many people would be on the floor at that time. And they were advocating for a ratio similar to what I'd be advocating for in the school system that reflects the needs of the patients. That's where I'm going with it. I know from talking to people, relatives who've had their loved ones, their like mother or mother-in-law, in long-term care facilities, or that they would be there every day, and they saw that there are many patients who didn't have, I guess, family to come in to see them, that there wasn't enough staffing. People would be left in their beds, sometimes wearing a diaper for quite a few hours, that they weren't got up and dressed for breakfast, and so on and so forth. So I guess what I'm looking for is that, what does the number of hours look like? If a patient gets 2 hours per day, how many people are we talking about? If you've got to get people up in the morning to get dressed, get down to breakfast, maybe to get showered, cleaned, that's a significant. That's intensive. A very human intensive operation. And in light of, I guess, a look at the AG report on personal care homes, there is a significant concern on the part of many people, certainly I've heard it since, about whether apprehension and fear even about even the thought of going into a long-term care facility, because they are afraid, very much so, that they will not be looked after. And I would say for many families who have aging relatives, that would be a significant concern as well. So that's where I'm after, is what is the ratio, and if you're looking at the staff, how will that work out, as opposed to so on a floor where each patient is getting 2 hours a day, I'm assuming that's during the daytime hours. How many staff are we looking at? How many in that floor? How many would that be in staff, right? So that's what I was going with it, and where I was going with it. And if indeed we could start looking at staffing it in a way so that the ratio is much lower. Okay. Are there any particular items from the Health Accord blueprint that we can expect to see rolled out in the coming year?
Minister Haggie?
I think the answer is there are items. Certainly, if you go through the Health Accord, and the author is very close to me, so I almost feel as though I'm getting it from both sides now. There's a lot of preventative stuff that tends not to be regarded in quite the same light as some of the more obvious bricks and mortar and staffing hires. But I mean, if you look at the health and well-being elements, they're out there and they will continue to roll out. I mean, wearing my other hat, we have well communities or community wellness grants, which we've put out there. Those are parts of the Health Accord blueprint. They wouldn't appear here, and you won't see them under any head of expenditure here necessarily. So there's those. There's initiatives that go through Minister Stoodley's other portfolio in housing. There are initiatives that go for nutritional supplements, increase in child benefit. We've had a massive reduction in child poverty in this province as a consequence of budgets before. So there are incremental progress, those. If you want to look at something more tangible, there's the ground ambulance integration, which was part and parcel of Health Accord. There's the air ambulance piece, which is coming out. There is the beginnings of a helicopter emergency medical service, starting out from the East Coast, which will begin to roll out. So each of these initiatives will have tangible landmarks, as it were, over the course of the next year. We've talked about, hip fracture units, the focus on provincial delivery of healthcare, the family care teams, the integration of primary care, the integration of secondary care programs. So there's a common general surgical program, a common internal medicine program across the province, rather than silos here, there, and everywhere. And each of those, whilst not necessarily a huge media announcement, is a tangible from the Health Accord.
Thank you. Has the department considered incentivizing entry into the nursing profession by paying nursing students for their work terms? Where are we on that?
Minister Haggie?
I think that question is was addressed by Minister Howell in the House the other day, looking at the fact that they have these work terms and receive not only no recognition for it, but actually have to pay tuition. And I would defer to her in that way. If you're looking at incentives for recruitment for nurses, we have got satellite campuses which enable them to have education closer to home. We've got incentive bonuses for signing and for returns in service. We have a bursary program. So I would argue that there are incentives. The specific one about work terms falls under Minister Howell, and I know, as she said to the House here, she's looking at it.
Thank you. And how much money will the integrated road and air ambulance service cost once completed, and how does that compare to previous spending?
I can't give you a figure from when it is completed because we don't exactly have a firm end date yet. We actually haven't signed a contract with Medavie. We've signed an MOU, and there is money allocated in the budget here, which is under a head of expenditure again, and it's scattered across salaries in the department, and it's also in one of the heads of expenditure. And had we gone through these in an order, I have my binder all nicely, neatly laid out, and would have been able to tell you as we went through. So I'm sorry if I don't want to delay you by rummaging wildly.
The member's time has expired. The member for Conception Bay South.
Thank you, Chair. Minister, as we're on the topic of beds, and are all the beds open in the Placentia Lines manner?
That's a good question. I will defer to Ms. Herritt, maybe, or Pat. Yep. We'll find out for you. I mean, we kind of came here expecting heads of expenditure and money questions, so we were prepared for that, but we'll find out for you.
No, that's fair enough. Thanks. Minister, wait times, how are we doing with the benchmarks?
Our wait times are longer than I would like them to be. There's no doubt about it. I think the only benchmarks that are national, we have challenges with joint replacements, but we have improved that. I think the wait times for cataracts have come down significantly, and I think you'll find they are within the national benchmark. Our wait time for radiotherapy has been a little bit suspect, shall we say, but our wait time for other cancer treatments is within the benchmarks as well. So in terms of exactly where they are within those benchmarks, I would have to go away and bring the data back. What I can tell you is that for our treatment results in the cancer field, we are either first or second in Canada. And where we're second, we're going to be first next year.
Good, good. MRI wait times, is there any improvement? I know that's been a much talked about issue. Are we making any strides to improve and shorten those times?
Yeah, particularly for Eastern Urban currently, they're down by 13%, the wait times.
And what about, well, this one here, psychiatric wait times, psychiatrist wait times, has there been any movement on that? Because that's been a fairly lengthy.
Minister Studley. Minister Studley.
Thank you. I will defer to Gillian, please.
Gillian Sweeney.
We continue to work on reducing wait times in each of the zones of mental health services. There continue to be differences between each of the zones based on the availability of psychiatry in each of the zones, so I can't provide a standard wait time because we don't have that figure given the differences between the zones.
Okay. This is another issue that's come up, and there's been some media about it, but I know I had questions, me and you had questions about it as well, and it's, but the issue is still outstanding. Pediatric specialists diagnosed with ADHD, we have speech pathologists in there, and we also have autism, of course. The wait times for that, children usually between the 2 to 4 age, 3 to 5 age, and that's where I focused at the time, was that there, and there's been the stories done on it, parents have spoke out, and there is a wait time. There's 2.5 year wait time, and I do know that in one exchange, I think it might have been with you, or I spoke to media, but I've spoke to pediatric specialists about this actually, and we discussed, I guess, is there another way of speeding this up, because you got a short window. And it's not something that you really should be delaying, because if they, they don't get that in the early ages, it could have a detrimental impact on them down life's road as they get older. So has there been any discussions on that? I know that you alluded that you didn't think it was an issue, but at the time you didn't think it was a serious issue, as we were saying. I can't remember your exact words, but it wasn't what I said. We weren't on the same page, but that shouldn't shock anyone around here. But I still believe, on a serious note, that it is a very serious issue facing a lot of young families. And I know I spoke to them throughout the province, but especially in my own district, I had numerous families that have ran into the 2.5-year period of wait time. So has there been any, I guess, discussion or plans on trying to address that? Is there any other medical profession could assist with the backlog?
Minister Haggie?
I would never accuse you of putting words in my mouth.
My answer never lies, Minister.
Yeah. Look, the short answer is yes. We provided some money to NLHS, and they are working on an implementation plan to add staff for the assessment for ADHD, autism kind of issues. We've also looking at the possibility of taking the long waiters or the worrisome waiters and seeing if we could work with the psychologist of the province to maybe find an initiative that we could fund through them to help address some of that backlog. A lot of our psychologists are actually not in the NLHS employ. They are they're independent contractors, so there is a potential there for access to skills.
No, I appreciate that. That is an important issue, no doubt. Minister, the Costco, the old Costco building, I guess, leases for the urgent care and ambulatory care. Any update on time frame, staffing, or where we're to with that building? Because I know there's a lot of things going in down there. Most recently, IVF, I believe, are using part of the building for providing an IVF clinic. So, are there any updates on staffing or leases or time frames?
It's a popular spot. I don't have an update. I'm not sure whether it would be Ms. Herritt or Dr. Palfrey who would be best to answer that. Sure.
Janine here.
So the timeline is anticipated for fall of 2025, and plans are underway for staffing.
I guess, though, and I guess the staffing is self-explanatory. That's the challenge. That's the challenge we face right across the province. So I guess there's no, you can't really answer that question until you actually go looking for staff, correct?
Minister Haggie.
I think my answer to that would be the same as the one before. We have significant bonuses to attract new staff. We would really rather have new staff go in there rather than poach old staff. We do have, over the summer, a new graduating class of residents who are currently, some of whom are currently looking for jobs. And by and large, our recruitment incentives do work. And they do work better for Metro than they do for rural, and that is a challenge for us in managing service delivery in rural areas. But I would anticipate that once it is clear as to what magnitude of staff we want and need and what that skill set would be, and I don't see that as being something that would take necessarily a long time to generate, then once that goes out, I would imagine a fairly robust response. Certainly before I left the last time round, jobs in St. John's were having between 20 and 40 physicians applying for them. There was no shortage of applicants.
Thank you. Yeah, so Minister, basically my question, I suppose, summarized. My point is it can be open and finished and all fully furnished, but operational, I guess. So your hope is, based on your past advertisements, your hope that it will be also operational this fall? I would hope that it's operational by the fall, and I don't know that there is any concern that that would not be the case. Now, whether it wants 7 doctors and by the fall we have 5, you know, you could still go, and you've seen that with some of our other family care teams. We've got the kernel of a family care team, and then we've got it operational to provide a level of service, and then we've worked to boost that. And indeed, some of the comments at the beginning about the 35 million for family care teams reference teams that already exist being bolstered and enlarged rather than just simply trying to create new ones. Thanks. Minister, there's been a lot of debate over this one as well, the personal care home issue, but something that I know my colleague from the third party has spoke out about a lot, but I've changed course with that, and it was about the evictions. So I do have a lot of personal care homes and community care homes in my district, and they're from one end level to care, they're one extreme, to the next, but I mean, I got some very, very impressive facilities too. So I had discussions with various homes, and a couple in particular, and I asked them directly the question about the evictions. And surprisingly, the answer come back was that, yes, I do. And I asked, do you mind why? Ask me why you do it. Because the system is failing, they feel the system is failing them because they got problem residents there. And this could vary from not to be able to provide the care to personality changes, a whole variety of things that we all know happens within the personal care homes. They feel they're being left with no other option. Now, this person in particular has only had to do it 2 or 3 times over a long period of time. And so it changes the focus on, and I think I heard your public commentary was they're not being dropped off in the parking lot. And I get that piece. When you read a report, you can make that connection. And any public record will show I've not mentioned that topic because I had a different view on it. But I guess my question on their behalf to you and your officials is, what's being done to help? We had a lot of good operators out there, as we both agreed upon, and now they're presented somewhere. Unfortunately, we're grouped into with everyone else, the not so good ones. But what's in place to help assist those homeowners that are trying their best to try to provide care to those people, and we're left, they throw their hands up, they have no other choice but to go to a merge or call an ambulance and refuse to take the resident back, which is quite sad in itself. But I mean, there's 2 sides to that story. So I'm sure you're aware of the other side as well. Is there any commentary you have on that issue?
Yeah, I mean, it is a difficult situation. I mean, you have to remember that personal care homes are essentially private businesses. They're landlords. There is a relationship of a landlord and a tenant, albeit modified by the fact that these are individuals who do need care. We're moving very clearly to a case management system for individuals in personal care homes, and I would like to think that with some of the changes we're making to the personal care home standards around evictions, that this would be a communications issue, so that a care operator didn't feel that their level of care for their client was such that they had to drop them off at an emergency department at 5 o'clock on a Friday night. That is totally the wrong time to do it. I'm not saying they all do it. I am aware of some that do, because I've been on the other end at the door at 5 o'clock on a Friday afternoon. So I think I would do 2 things. One, I would encourage them as individuals to use that case management system to talk to the individuals concerned. Reassessments are straightforward to organize, and we put 17 FTEs into the system across the health system last year to enable assessments to be done more rapidly and monitoring to be done more closely. And at the same time, I would listen to the commentary of our staff as they speak to personal care home operators who live this. I think the numbers are actually small. When you look, there's 4,500 people in personal care homes, and over the period of the AG's discussion or monitoring, there were 91 that were dropped off at an emergency department, and that's actually a very tiny percentage. Again, like with the other incidents, it's a number I'd like to see at 0. But I think we need to be careful about crafting a blanket policy to deal with a very small percentage of individuals, because that's not good policy making. But you and I walk the same set of lines because of both sides of that issue.
Okay. The member's time has expired. The member for St. John's Centre.
Thank you, Chair.
No, I'll do afterwards. I can manage for 5 more.
With regards to personal care homes, I know one owner reached out to me, and the comment was, with regards to equipment, that even if they wanted to, they would like a chairlift, they would not be. It would not be supported by Newfoundland and Labrador, the health services. I'm just trying to get an idea. Like, so if they use a chairlift to take a person off the off the floor who's fallen. To do otherwise, I guess, would risk injuring workers, but I'm just trying to get an idea of what is it then that personal care home, when it comes to equipment, are permitted to use or not use, and if that's a problem, because it was put to me that, like, if they could access, in this case, the owner said, look, I would pay for the equipment myself, do the training with the staff, and make sure that it was used properly. But that would be a huge help in keeping people in their personal care home. So I'm just trying to get an idea of what is the policy, or is there one from Newfoundland, from the health services, or from the department?
Minister Haggie.
The only specifics around that I'm aware of is if a home wants a piece of equipment, NLHS will supply it if it is clinically indicated for that patient. But I'm not aware of anybody telling anybody that they can't use something that they have already.
So if they wanted to go out and purchase it themselves, or in other words, it would have to go through health services, and it would have to be, I guess, identified that the patient would need it. So if someone falls, you need to get them up off the floor. They can't get up on their own. But a chairlift or some sort of a device would help them. It's that I'm just trying to get an idea, is that it would have to go through it. Would it have to be approved by health services first, or it's up to them what equipment they use? If they want to train people themselves properly, and if they want to purchase it, are they able to do that if they wish?
I will defer to Ms. Herrick, but I'm not aware. The only thing I said was if they wanted a piece of equipment for an individual and wanted us to pay for it, we would only do so if it was necessary for that patient's clinical care. But that's what I said.
Yeah, no.
So,
Janine Harrod.
Janine Harrod. So in a personal care home, the use of equipment, again, ties back to the levels of care that we spoke about earlier. Based upon clinical assessment of the client, as ministers noted, the health authority can work with personal care homes to implement appropriate equipment in the personal care home setting. It is an individual assessment based on the client and the factors within the home as well, and ensuring that staff have appropriate training and are able to use the equipment effectively. So I think there's not a one-size-fits-all answer, but more of an individualized assessment depending on the home, the particular needs of the client, and the ability of staff and the knowledge around the equipment use in the personal care home setting.
So if I may, then it would have to be approved by health services. If they, and I guess here's, like, if I own a home, look, I need my chairlift or whatever else, we got a patient there, we'll buy it, we'll train the staff according to the standards. Would I be able to do that? Or does it have to go through the health
Janine Harrod. So that would be a discussion with the health authority to determine the appropriateness of the equipment, and again to discuss things such as training needs, which the health authority would have a role in with the personal care home depending upon the decision at hand. So it's not an individual personal care home decision. It would be a decision made in collaboration with the health authority, and of course in line with the operational standards.
And I guess even if the personal care home was saying, look, we'll pay for it ourselves.
Yes, so
I'm just trying to clarify what I was told by this versus what you mean. So if I said, look, I don't want the health authority to pay for it, quite happy, we'll pay for the training. You certify them, and we're happy to go with that. So I'm just trying to say, in that case, they would still have to get the approval, I guess, of the health authority.
Minister Haggie.
I think the concern is from the other point is this an appropriate piece of equipment to do the job you wish to do? And it's knowing whether or not there is the skill set there to make that decision, because there are different types of lifts available, there are different types of sit-to-stand devices, and I think the caveat from our point of view as a department is to make sure that the staff in the home know which to use, how to use it. It's decision-making and training, not the actual equipment, that is the cause of what anxiety may appear in this process. It's not a desire to deprive the home of anything. It's a desire to make sure both the people who are operating that equipment are safeguarded as well as the individual they're using it on.
Okay, that makes sense. In other words, you can't have one piece of equipment and then they decide, well, I'm going to use it in another, okay. Or another patient who may have something similar but not quite. Okay, I would like you, if you possible, to take me through the consultation process with Janeway pediatricians with regards to the integration of the gynecological services into the Janeway. I'm trying to get an idea. It was said today that the process has now begun. I'm just trying to understand the timeline of this process.
Minister Haggie.
As I said in the House today and on previous occasions, there are a multitude of possibilities about how best to use the resources that are present on the health sciences site and the Janeway. At some point, those consultations have to begin. I think that equally well, and Dr. Parfrey can probably speak to this with more granular detail, at some point, somebody feels that someone else knows something they don't. And the minute that happens, people start to get worried and defensive and reactive. So having said that, and acknowledging that we are at the beginnings of this, I think it would be sensible just to ask Dr. Parfrey if he wanted to add anything to that analysis.
Dr. Parfrey?
Sure. Maybe I might be a little bit long-winded here now, but the Health Accord mentioned three things in relationship to children's health. It mentioned the issue that Mr. Patton brought up about wait times for certain outpatient stuff, like autism and developmental delay and mental health and addictions, etc. And the response was currently is to develop a child health model that integrates the health side with the social workers at CSSD and the educational system. And I'm optimistic that that solution will roll out over the next short period of time. The second one was around the Children and Youth in Care Clinic, which is a community-based clinic that provides wraparound services to children in care, and recommended that be increased. That service is currently in a bed part of the fourth floor of the Janeway, occupying a patient bed area. And then the third part was around developing the Janeway as a children and women's hospital for two reasons. One was that the number of children has dropped by half since 1990, and the sustainability of the Janeway would be enhanced by having services that were targeted for women. And in particular, it was also considered that targeting services for women was dealing with a neglected area, and this would be able to enhance women's health, particularly around menopausal therapy, prevention of cancer, access to cardiac disease where they're underdiagnosed and undertreated. So that proposal has been made, and as a consequence of that, obstetric services have been planned to be transferred from the Health Sciences Centre to the Janeway, and a new 28-bedded obstetrics unit has been approved and is meant to go forward over the next number of years. The renovations are substantial. And the other thing that's happened is that gynecological surgery has started in the operating rooms of the Janeway. So in the last period of time, we've had large problems with adult patients being in the corridors of the health sciences because there's no beds available to them. And we've investigated a number of different ways of being able to identify acute care beds for those people. And one of the potential areas was the area that the kayak clinic occupied in a bed area of the Janeway Hospital. And that potential solution would have no effect on the pediatric beds. So the thought process around how to solve our problem involved meeting with the pediatrics group, the Janeway group, in March, and Dr. Greg Brown, who is the clinical lead for infrastructure and clinical transition, was the person who had that initial discussion with them and what their opinions were. And I subsequently then met with the pediatrics group separately last week and spent an hour and a half with them probably, and then met with the gynecological group a few days later, all within the last period of time. And it was agreed that we would continue to engage about what the solutions could be and what the problems would be, and that we'd also examine what other hospitals are tending to do when it comes to the role of gynecology in a children and women's hospital. The reality, I think, is that the pediatrics group of the Janeway believe that this should be a children's alone institution, and we as an executive are concerned about how we can deal with a bigger risk, which is that we have people in corridors, adults in corridors, that could get beds if the gynecology unit went to the space that's occupied by the Kayak Clinic, and we were able to use those beds for acute care. So that's just a long-winded background to what's happening. There has been no plan delivered to the Department of Health and Community Services, and we have not finalised the plan in terms of how we would deal with the problems that we've currently got. So engagement will continue, and for example, the Isaac Killick Walton has a children and women's hospital, and Dr. Brown is going to visit there with the principals that are involved in pediatrics and gynecology, and we will continue to engage.
Okay, thank you very much. The member's time has expired. We're going to take a break now. We'll come back at 7:50. Yes. Okay, we are going to start up again. The member for Conception Bay South.
Thank you, Chair. Minister, the extended stay has been used by on Lamarcham Road has been used by as a hostel for, I guess, for a nice number of years. Is this still presently being used as a hostel?
Minister Haggie. Minister. Okay.
Yes.
Yes. Do you have any idea of the cost per year?
Not offhand, but maybe Mr. McGrath might be able to get it for us.
Deputy Minister McGrath.
If we don't have it, we'll get it.
John McGraw, I will get it.
Don't forget this time, though.
We do have it. Patrick has it.
Oh,
Patrick Morrissey.
Patrick Morrissey, yeah, so it's $258,500 a month.
$250,000 per month?
$258,500 per month.
Not a bad gig. Has this been, so there's no, has there been any plans of purchasing this or just continue on to monthly rentals?
Minister Haggie.
Yeah. At the moment, until we know exactly what's going to happen with hostel accommodation and the need for it, this seemed to be a reasonable short to medium term measure, while the rest of the requirements for the health science and mental health and addictions facility were determined.
The downtown clinic, timelines and staff, I think I asked this during transportation estimates, if I'm not mistaken, and I was told that this was under health. So any update on that? That's the downtown wellness, is it the wellness center? Where's it going?
Hang on a second. The downtown wellness.
The downtown wellness clinic, yeah.
Okay, hang on a second. I will defer to
Dr. Parfrey.
That's the proposed site for the Downtown Health and Wellness Centre at the Grace Hospital. And it's got 4 elements to it. One is a step-down unit for psychiatric care in which there would be 20 beds that would be created for people who've been started on their drugs but they need to be stabilised on their drugs. So it would also house the community-based programs like ACT and FACT, etc., those other community-based endeavours, and would include a transfer of the Pleasantville Detox Centre to the same site. And then the other part of the site would contain a family care team for the downtown, and eventually would have an urgent care team to replace the emergency room at St. Clair's when St. Clair's was finished. So that's just being planned and hasn't yet had an approved budget from the current government.
Thank you for that. I guess that's to do with the void that's going to be in that area where it's the downtown core, and St. Clair's will no longer be there. So, okay, makes sense.
Sorry. So the family care team would be particular to the downtown and would function as a hub for resources that would go to places like the Gathering Place and Choices for Youth, etc.
Okay, makes sense. Minister, Heart Force One, any data on the usage of trips and the costs?
My understanding is that it's moved 241 patients as of the end of last calendar year. I'm not sure exactly how many flights that would have been over. And as to the cost, I would defer to either the comptroller or John.
Chad Antle.
Yep, I don't have that on me now, but we can certainly get it.
Cardiac wait lists. We've had new labs announced, and we've been sending people to Ottawa. We still have 200 on our wait list. What's the reason we can't seem to get that number down? Is cardiac issues increasing that much, or are there other issues within the system that's causing the number to stay at 200?
It's a victim of success temporarily, as it were, in another area. The cardiac cath lab is working more efficiently and processing more patients. The vast majority of people who go for a cath will have, where possible, an interventional procedure like a stent or an angioplasty. But there's a fixed percentage of those individuals for whom that doesn't work and who require cardiac surgery. So what you've done is you have increased the volume, but because it's a fixed percentage, that number increases at the other end. So that is what's driving the demand for cardiac surgery at the moment. We have an arrangement with the Ottawa Heart Institute. There is discussion with the cardiac surgeons about adding another FTE, another full-time equivalent cardiac surgeon, to our roster, and those discussions are well underway, and that should raise the opportunity of increasing throughput at the cardiac surgery end, and those discussions are well advanced.
Okay. Minister, missed appointments. I don't know, does the department have any stats this year? It seems like we send appointment reminders for everything, but a lot of things we don't. So is there anything in place or anything being worked on to try to decrease that number? Because we all know that's a big issue within the healthcare system, and it's driving everything from cost, you name it, to efficiencies, to access to services, obviously delays in getting with this issue. But it's a big issue, and it's probably don't be talked about enough. So is there anything internally being worked on to try to eliminate or lower that missed appointment rate?
Yes. It is an issue, and if an appointment is, someone can't make an appointment and we know about it with enough notice, we can use that for somebody else. Obviously, at the very last minute, if some prep is required, like for a colonoscopy where you need a couple of days notice, that isn't always as easy. Basically, it's a notification system, and depending on where you are, it's either automated or it's manual. We have an automatic notification system, for example, for certain areas in Central, for ambulatory non-invasive cardiology, for example. You get a little thing on your phone, you have an appointment. Are you going to go? Press 1 if you are, press 2 if you're not. And for others, it's clerical calling to try and reduce these. Where we've had those in place, even 10 years ago, we could reduce the no-show rate for endoscopists, mine particularly. I know it's 10 years ago, but it worked then. We could reduce that to 2 or 3% from anywhere from 20 to 30% sometimes.
Minister, any update on the geriatric health care centres that's been talked about?
That's based on initially really a hub and spoke model. There is the makings of one at the Miller Centre. I think the discussion then is how best to put these in other locations. One of the challenges really is, whilst you could maybe find a geriatrician, a solo practitioner without support in that area particularly is a very difficult proposition. What you need to look at is space. What you need to look at is rehabilitation services, physio, OT, that kind of thing. So, for example, the transitional beds in Corner Brook will be an excellent addition to that kind of armamentarium. And we've had discussions with NLHS about how to kind of clone that and get it out there. One of the challenges as a country, Canada's training system for residents, which is a system that's so bizarre and arcane some days I wonder who ever designed it, does not train many geriatricians. The last figure I saw was 18 a year. It just doesn't match our demographics, and yet it's been very difficult to change that because of the hold of universities and others in maintaining the status quo.
Thank you. Minister, the health system information update, I know you spoke about it in your opening remarks. It's a large budget item, as we all know. It's $600 million. Is that system, do you feel that that's, I guess, of good value for money And I know we've gone through cyber attacks, and we've gone through most recent ones in education throughout. So it's become a more important issue than just some people would glaze over it not so long ago when you'd mentioned it. Some still do because they don't really understand it or appreciate it. So I guess with that amount of money being invested, it's quite a large sum of money. Is that something that you're, you know, what's your hope for, what's the outcomes you're hoping for when this gets implemented?
Just for an update for the House, we're on time and on budget, and it's not always you can say that, so I'm really pleased about that. This is a game changer for clinical care in this province, both for the clinicians, for the administration who can use it for real-time decision support, and for the patient, because it interfaces with all of those areas in a way that allows access to information, so you would be able to ultimately read your own chart in the comfort of your room at home. You can integrate clinical decision with lab tests and these kind of things. And essentially, it takes Meditech and a lot of the legacy systems from the clinical front end and plugs them all in together. We have a separate approach for the back end, which will really be around facilities management and payroll and administration. But that's rolling out in parallel as well. And will yield huge dividends. But the health information system is a clinical front-facing thing, and I think it will be a huge improvement. There will be a change management piece, because everyone's used to pressing button A and button B to get where they're going. And when you change that, they'll not be happy in the early days. So we need to learn from the challenges we've experienced in the past and do a good job of that change management, and that's been a big part of our discussions with OCIO and with other folk who are project managers on this.
Okay, member's time has expired. Member for St. John's Centre.
Thank you, Chair. I'll go back to the consultation process, but I do have a few questions in the meantime before I do that. So right now, as I understand it, there are more patients than beds at the Health Sciences Complex, the Health Sciences Center. So why is that? I know when I was last time I was at the St. Clair's, there are an awful lot of elderly people in the emergency ward. I would assume for some of them they have no other beds to go to. Maybe they should be long-term care facilities, and I've heard that from doctors at St. Clair's that you could free up space if there was long-term care beds available. So I'm just trying to get an idea of what is the issue at the health sciences.
Minister Haggie.
Now it's as much demand as anything. There are no opportunities yet, although we're working on it and have some steps in place already for going right to the front end. So treat and leave options using advanced care paramedics and community supports all the way through to the rapid discharge of patients to an appropriate environment, be it the one we've all heard about is long-term care, but there are opportunities for early discharge after surgery. Health Science Centre has a program that's been rolled out to some extent in other centres, because the ALC problem at Health Science Centre is actually a lot less than in other areas now because of some of the manoeuvres that have been possible in town. So it's an issue of demand management and flow that is the problem in the Health Science Centre at the moment.
Would it be possible to have a breakdown of the number of either alternative care, level care, or long-term care patients who are in St. Clair's and in the Health Sciences Centre?
Yeah, just specify a date or a day, because it does change by day, but currently the average for the Health Science Centre site alone is around 9%. As to St. Clair's, I don't have that figure on the tip of my tongue.
Okay, then I would certainly, let's say I would certainly look over the last few months. So I can send you the specific months or the dates, and you can give that to me a snapshot.
That's right.
Perfect. As I understand it right now, would you be able to confirm if indeed Janeway diagnostic equipment, MRIs and so on and so forth, are being used for adults? Is that the case?
I would defer to either Janine or Pat. My understanding is that in the past the CT scanner has been used in that regard, but that was back in some years ago. So I would defer Janine, Pat.
Dr. Pat Parfrey?
Sorry. So my wife was a pediatric radiologist, and to be able to sustain pediatric radiology, they decided to be able to get an MRI and get a CT scan. They decided that they needed to extend the service to adults, and particularly cancer. So to be able to provide a sustained pediatric radiology, they needed to increase their volume in other arenas. So those radiology services have been used by adults for over a decade, both the MRI, CT scan, etc.
Have any, children been bumped or had their services canceled as a result of this?
I doubt it very much. There's a very strong connection between pediatric radiology and the pediatricians and the pediatric surgeons in the Janeway. I can't give you chapter and verse, so, but I think that they run a collegial service that includes pediatric radiology and includes services to adults as well.
Have there been any diversions? I'm just trying to think here. Diversions of children to other hospitals from the Janeway?
I can answer
for the pediatric intensive care and.
Minister Haggie.
Yeah, the last ones I was aware of was during COVID, but again, if Dr. Parfrey may have a more up-to-date figure, I'm not aware of any currently.
Dr. Pat Parfrey.
Yeah, sorry. I'm not aware. You're talking about pediatric ICU. Is that what you're talking about, Mr. Dinn? Yeah, so there are 6 beds staffed for pediatric ICU. And they have, on a number of occasions in the last year and a half, hit 4, and then they have an extra 2 that they can use in addition for pediatric ICU if there's a surge. The occupancy for the medical peds, medicine and surgery for pediatrics, they have 33 beds, and they haven't gone above 80% any time in the last year and a half.
Have there been any children who've had to spend an overnight in the emergency ward because there was no bed available?
Do you want to answer that?
Dr. Haggie?
I'm sure Dr. Parfrey would be able to tell you, but if there's always 20% beds empty, it seems unlikely. But Pat?
Dr. Parfrey?
I mean, I can't give chapter and verse, but it's a very unlikely event in the fact that because, as Dr. Haggie said, the occupancy has never been over 80% for the medic and peds, medicine and surgery.
Is there, with regards to the Janeway, I think you had said that the doctors believe that the Janeway should be a children's only hospital. So I would ask, why shouldn't it be?
Minister Haggie?
Are you asking me? If you're asking me...
I'm asking either, whoever...
Well, I'll tell you. It is a pediatric tertiary service for the children of this province.
So I'm looking here, and maybe you can correct me if I'm wrong, but I suspect not in this case, since it's the doctors are putting forward, of the 11 hospitals, including the Janeway, which are tertiary quaternary care pediatric healthcare centers across Canada. None of them offer adult gynecological services, and only 2 offer obstetric services. which will be in separate buildings. That's the CHU Saint-Justine, Montreal, Quebec, and the IWK Health Center, Halifax, Nova Scotia, because I think you talked about taking doctors to, or some of them on a tour of some places to show how it works. So none of them, I guess, have actually taken over space in the Children's Hospital to accommodate this. As a person who's brought his children to the Janeway when it was in the old building, and someone who's had to bring his grandchildren there in the new building, and it is a purpose-built hospital. So again, I guess, why shouldn't it be when we, when in every other, or no other jurisdiction is attempting to do what we're doing? And here it seems we're trying to solve an adult care, acute care problem by taking from the Janeway. I'm just trying to get an idea here. Why wouldn't we build on the space we need to the health sciences, or find a way to move those who might be in long-term care or in need of into another setting? Will you can answer that, please?
Minister Haggie.
Yeah, these three issues there that you raise, or three topics, I think, first thing, and I've said this repeatedly, no diminution of the services available to the children of this province. And the second thing is, this is part of the consultation process to do jurisdictional scans. You have presented some information there, and that will be very helpful. And finally, the issue about building only comes at the very end. If there is unused and empty space in a facility, it is beholden on all of us to use what is the province's most expensive real estate in a way that makes sense for the most benefit. We're not taking anything away from anyone. We are hoping to add to the services that are generally available with whatever we do. But this is a consultation process, and we're at the beginning of it.
Member's time has expired. Member for Conception Bay South.
Thank you, Chair. Minister, update on the fertility services clinic, I guess proposed new clinic. I guess what are we looking at? What's that going to look like when it comes to fruition? The easiest way to ask him.
Minister Haggie.
It will be an expansion of services currently. We've increased the supplement, as the member opposite is aware. Across Canada, some of these services are insured by provincial health plans and some are not. The discussions at the moment with the two physicians who want to offer this service as part of a clinic that's already run through Eastern Health are underway about what it is they would need and what it is that needed to fill the gap. And the desire from our point of view was to have something in place by the beginning of 2026. You know, it would appear that some of their announcements now are quite optimistic in terms of a timeline. So exactly what it will look like will depend on those discussions. But essentially, the desire is to offer a package that minimizes the need for residents of this province to travel.
Thank you for that. This question came up last year. Several of my questions are repeats, and I was supposed to get the information after we had estimates, but that never came. The final cost of the cyber attack.
Minister Haggie.
The bill I've seen so far is $16 million. The investment going forward, I mean, we talked about health information system. That's you know, that is cybersecurity. In addition to that, there's some implementation money for the Gartner report, which I think is another $1.5 million for this year, specifically for the budget.
Did you pay a ransom?
Minister, I know this is an issue asked many times. Was there any ransom paid?
I don't know that I'm actually at liberty to disclose anything about that. I'm afraid I'm not up to date with what the public pronouncements have been. The last I heard was that we were neither to confirm or deny that that was the case.
Family care teams. I know there's been a lot of numbers on family care teams. What is the status of family care teams? How many are presently open or on the verge of opening?
20.
20. I know last year during estimates, the former minister made reference that there was plans to have something in Conception Bay South, which by no accident is my district, and we severely lack healthcare services. We don't have no public transit, and I'm smirking because Dr. Parfray, when he was doing the health accord, we had a couple of times, I believe me and my colleague actually had a couple of meetings with himself and Sister Davis on the same issue. And at the time, we were an ideal location for collaborative care. Now it's gone to urgent family care, but of some form of health service. And the former minister, as much as alluded that we were in line, there was something coming our way. But again, I wait. Is there any proposed plans or discussions to address that?
Minister Haggie.
I'd be happy to look at the member's concerns for his district.
And I've been around a long time to know what that answer means, so yeah, okay.
You could be surprised.
Listen, nothing surprises me anymore, but you never know. Minister, with those urgent family care teams, this issue has been talked about a lot. It's been confused, it's been complicated. The rostering. We hear rostering as, in its overuse or misuse. If you're rostered as opposed to being able to see a doctor, there's two distinct differences there, right? So if you're rostered, where did that put you online and being able to see a family doctor?
The idea of rostering is you have a family care home. You know where to go if you have a problem. You would go to the much hoped for CBS family care team, for example. That's where you go. What happens to you when you get in there depends on what your problem is at the time. So, and it also depends on the resources in the clinic. So, for example, if you have a fairly routine prescription refill, for example, if the family care team has a pharmacist on staff and that pharmacist is there that day, you might actually see the pharmacist. Or, if not, the nurse practitioner. 80% of primary care can be done by nurse practitioners, unsupervised. And that was the whole idea of altering the Medical Care Act to make sure they were autonomous practitioners. The role of a family practitioner is to deal with those complicated cases where a kind of arbitration needs to happen. You have 5 comorbid conditions, which is not unusual in this province. Each of them is treated with what's called an algorithm, a recommended set of treatments followed by a physician or a nurse practitioner. Once you get more than 3 of those, they fight each other. Then what happens is it becomes an arbitration between the patient and their primary care provider, their physician. Which of these is more important to you? Is it the fact that you can't get these nice shoes on and your ankles swell when you want to look good when you go out? Or is it the fact that your eyesight is a problem or you've got numb hands? How do we best treat those when the drugs for one will make the other worse? Which matters most to you? That's the role of a primary care provider. It is for the complicated cases that are not easily managed simply. So the answer to your question is, you go to your medical home, your family care home, primary care home, and it depends. What do you need? We get what you need.
But there's no guarantee you're getting to see a family doctor, per se. If those people can't help you and you get something more serious, you end up most times going to emerge. Am I correct?
At the moment, there is a gap. That's what the urgent care centres are for, because, again, there's another metric to be looked at. If you go to your primary care home with an urgent complaint, how urgent is it? And you can quantify that. There's a Canadian triage score, CTAS 1 to 5, okay? 4 and 5 are straightforward, elective, daytime stuff. Unfortunately, because of a lack of access to primary care in the past, the only place they could go was emergency rooms. And that's why they sit there, because they're triaged on clinical need to the lower end of the list. If you're a 3, maybe you should have called an ambulance. If you're a 2, you shouldn't be at a family doctor's clinic. You should be in an emergency room. So that metric has to be dealt with as well. So most family doctors will have an ability to fit in a walk-in, someone who is ill, couldn't make an appointment because of sudden onset, and they would normally fall in a kind of C-test 3. Maybe they're ill, maybe they can be managed by a primary care provider. An urgent care clinic is different again, because if you've cut yourself and you need stitches, currently, the only place you can go is an emergency room. If you have an urgent care clinic, there are care providers who can do that for you. It could even be an ACP. So they're slightly different, but they're related. Because if you've got a really bad chest infection, you could be urgent and therefore need to go to urgent care rather than try and fit in to your primary care home. So the answer is there will be options, and it depends. And if you're out of town, you could even ring 811 or Teladoc and get that determination.
Minister, the Lionel Kellan Hospice had bridge funding last year, and I guess they're wondering why this funding wasn't increased as more funds have been needed and as successes in the operation of this facility. So I know the funding wasn't increased this year, even though they wanted the funds increased. Is there any rationale or reasoning for that?
They did get an injection of funds last year. The discussions at the moment are around what their operational needs are. That negotiation is actually still ongoing and hasn't concluded, so there's been no conclusion as to what money they would require for this year yet.
Okay. Final wrap-up, not final, it'll never be final, but a family doctor, what's your numbers on the people without a family doctor in the province right now? Because they're not the same numbers as Dale NMA, and I guess we've been using. What's your numbers on the family doctor shortage?
You and I have butted heads over what that number is. The fact is, one without a family doctor is the wrong number. You and I can argue black and white. The NLMA have a very, very strict set of questions they ask on their surveys to decide whether or not you have a family doctor. And most of us who actually think they have a family doctor would not actually get that on there. So I'm not going to argue numbers. It's pointless, because anybody who hasn't got one is a concern to my department.
Member's time has expired. Member for St. John's Centre.
Yes, thank you, Chair. Minister, is the Janeway staffed appropriately? I guess where I'm going with this, are the beds, if there are beds empty, is that because we got a very healthy population of healthy children, or is just that you don't have, the staff has not been provided to keep the beds open?
The empty beds that I've been referencing at the Janeway are staffed beds. The problem that we have is demographic. As I think Dr. Parfrey alluded to, and I have certainly said, if you look 10 years ago, our paediatric population was probably double what it is now. And the planning for that new Janeway facility, which is now no longer new, was made at a time when the paediatric population was even larger. Our birth rate is 3,400 or 3,500 a year. We have 67,000 children in the school system. We do not have the children we used to have. And even with immigration, all that does is it holds the decline to zero.
So I know last year there was extra units added into the school system basically to accommodate a full, I think it was roughly in the metro area, a full school, a population of children that came into the metro area. That's a significant number of students and of children. So I know that based on this, what pediatricians said, from January to 20 March 2025, 15 patients were delayed transfers out of PICU due to a lack of beds. 3 critically ill children were transferred out of province, 24 sleep studies were canceled, numerous surgeries and oncology admissions were delayed. I guess that's my concern. Also, with immigration, with newcomers, there's probably a whole host of conditions, diseases such as sickle cell anemia that we probably didn't experience before in Newfoundland and Labrador. So there is, while the model, you referenced a declining birth rate, and I would agree with you on that, but if I'm even if I'm looking at some of the people in my district, newcomers have a larger than normal family, and it's good to see the more children. That's for sure. I have a question then related to the consultation piece. On March 11th, there was a presentation given, and it was very clear. I think that was doctors understood that that wasn't about here's what, not asking what do you think, but here's what's going to happen. I think then Dr. Parfrey said he met with the doctors on the 7th or so in the early part of April, and made it very clear at the time that no decisions had been made. And this is more or less about consultation. But again, what really threw the monkey wrench into it was that on April 9th, 2 days later, the budget comes out, and it's got a very clear line there that $3 million for the redevelopment of the Janeway Children's Hospital and to relocate women's health services there. Now, the doctors, I think they would accept that when it came to obstetrics, that's a natural continuation, hand in glove, when it comes to maternal care and to the children's care. But obviously, it came. All those assurances went out the window when we saw in the budget that there was now a budget line of money allocated for it. It sort of belied the whole notion that this is consultation. So here's what I'm looking for. I would love to have a copy of the presentation that was given to see if indeed it was about a proposal or the research. We've seen what the doctors have put out. Be interested to see what was presented to the doctors, what caused the consternation. And secondly, I guess the key thing for me is Dr. Parfrey said engagement will continue. And the question I've written down is how. What is the timeline now? Because in this report, doctors made it very clear not only about consulting, doing further consultation with them, and I'm assuming that this document that they presented to you, Minister, to Dr. Parfrey, and to, I think, Dr. Greg Brown, will be the basis of further discussions and consultations. But I'm just wondering then, if this is the beginning of the consultation process, how will this look going forward? What are the plans? Because if indeed the consultation and the conversation has started, where does it go from here? And when will we see public consultation with families and with the stakeholders, people who've been donating to the Janeway?
Thank you very much. I mean, these presentations that you allude to, I have not seen. They were maybe the ones that Dr. Parfrey alluded to that Dr. Brown made. There is no line item in the budget for this as such. The reference to the money for the Janeway, my understanding was it was to deal with the changes required around the obstetric piece, which, as you said, would appear the Janeway paediatricians have a little aversion to. I'll probably get Dr. Parfrey to allude and describe his views of what's next and what the timeline is. I can't really shed any light on that, having not been directly involved. And just for clarity, I have received no communication as of coming to the House today from anybody about this particular issue.
Dr. Pat Parfrey.
I do think there's a bit of a misunderstanding about the $3 million that is in the budget. The only plan that's gone to the Department of Health and Community Services has been around obstetrics. The Health and Community Services have received nothing around gynecology. And the engagement process that we have discussed has been on that basis. So we intend to take people to the Isaac Hill of Walton, and we intend to take account of the objections of the pediatricians in terms of the fact that they wanted to be a child-only hospital, as against the other needs that are there as well. The timeline, there's no given timeline to coming forward a recommendation that could be made to the Department of Health and Community Services.
Thank you. So the hospital then, I just, the one that you refer, that has, where is that one located? Halifax. So this is the IWK Health Center. And I've seen the map, the layout of it. Again, this is it's two separate buildings, correct?
Dr. Parfrey?
I assume so. I'm not an expert in what's going on there. That's why people are going up to visit it and to discuss the issues that they have to deal with and how they solve them.
If you look at a diagram, it is indeed two separate buildings joined by an intermediate building, but there are two separate buildings for gynecological services and the obstetrics. Okay. Thank you for that, Lise. And is there a plan then, I guess, the consultation process from Newfoundland and Labrador Health Services point of view? Where do we go from here with regards to this?
Minister Haggie?
From my, excuse me, I'm losing my voice. From my point of view, once Dr. Parfrey and his team have done their work, then the discussion will revert to what to do with the empty space and the problem of over-occupancy in the other facilities, because those problems do need to be addressed. You know, I think Dr. Parfrey has done his best on the fly to describe a consultation process. And it is obvious from the member opposite that he has some detailed knowledge of one view of this problem. So, I mean, I'm quite happy to take that into consideration, and indeed would be, this is the whole point of having a consultation process. There is no idea that can't be improved by listening to other people, and we've found that out over the years. So that's the value of consultation, and we're right at the beginning of this, so I think it would be rash to make any commitments to anything one way or another, except we're here to talk.
Thank you. What work is this department doing or responsible for? What work is this department responsible for administering the Aging Well at Home grant? And what is the budget for the program in the coming year?
Mr. Haggie?
If the member opposite will indulge me, I will endeavour to try and find that, because I'm still at 1.1.01, and I think that's a long way down in the book. Have you got it there? Are you going to find it faster? All right. Grants and services somewhere.
Deputy Minister McGrath.
Hi, John McGraw. So that's part of the seniors' well-being plan. The total budget for that is $10 million. The grant itself, I believe it was the Aging Well at Home grant, that's administered by Newfoundland and Labrador Health Services.
Okay, the member's time has expired. The member for Conception Bay South.
Thank you, Chair. Minister, what's the status of expansion of the Fogo Island Health Centre? What's the status of that expansion?
Mr. Haggie.
My understanding is that the RFP is out, but I would not know any greater detail than that. Maybe Dr. Parfrey, Janine. Maybe Janine might be. No?
Deputy Minister McGrath.
Hi, John McGraw. Yeah, I believe the RFP is out. I will confirm that just to make sure. And that work is ongoing for.
Is there, Minister, any plans to expand Shedevac flights to North Coast?
Minister Haggie.
That's usually a discussion between Labrador, sorry, it's not Labrador Grenfell anymore, it's Labrador Zone and Air Borealis based on demand. I know that there is always a discussion and there's always some back and two about what should go on those flights. So I would defer that to them in detail, but my understanding is that that is a regularly discussed issue.
Thanks, Minister. Minister, in the financial statements for the Health Authority, there was an operating deficit for 23-24 for $640 million. And that's the most recent documents we have, up-to-date documents. So would this amount been approved by the Minister?
Minister Haggie.
That is in large part made up of an operating line of credit, and that is a cash flow issue over the course of the year, and that is the prime aim from the department's point of view of the line of credit. There has been some discussion with NLHS about the magnitude of that line of credit, and those discussions are ongoing.
What's the projected operating deficit for 24-25, Minister?
If someone could point me towards the line item, I would be grateful, because we're kind of dancing around a little bit here, but just bear with me and I'll dig it out. Okay. It's not in the estimates. Not in the estimates, but Mr. McGrath will enlighten it.
Yeah, so for this fiscal year, I don't believe that NLHS, Newfoundland Labrador Health Services, would have their last quarter or number of months closed off yet. I know at the end of the year, certainly I think everyone can appreciate there is money transferred around to try to pay down that deficit. I wouldn't be able to speak to right now what that would be without going through the Auditor General or seeing audited financial statements at this time.
Thank you for that. Any directives to deal with this deficit?
Minister Haggie.
There have been significant discussions about how best to deal with this deficit. There have been several initiatives, not least of which was combining the 4 RHAs into a provincial health authority to try and cut down on back office duplication and expense. We're at a stage at the moment with the health authority that we are investing to save. That is the paradox of this, the issue around the health information system, the issue around the ambulance integration, the issue around the back office functions are all part and parcel of a broader strategy to get fiscal tracking of things that currently at the moment are actually a lot harder to do because they're on pencil and paper and they're not easily done real time. So in terms of real time decision support, that's where we see over the time supply and inventory management and these kind of things paying off. So there are a variety of strategies in place and evolving to deal with that.
In 23-24, the line of credit was $693 million, with $648 million used. So, I know Mr. McGrath just said they haven't had the most recent numbers, but does the department have any idea the current amount used as of today, or approximate? Any figures?
I don't, but maybe Patrick.
Patrick Morrissey.
Patrick Morrissey, yeah. So the current line of credit being used right now is $665 million.
Thank you. Minister, supplies inventories 23-24 was $9 million in the pandemic inventories. So as of today, are these supplies still usable? Because I know back during COVID time that there was an awful lot I'm at a loss for that outbreak, but it's leave me. But I think you know where we're going. They had to be destroyed. They were outdated. So is there any idea on that amount, that $9 million in pandemic inventories, is all that still usable, and is the expiry date getting close, or where are we to with that?
If you recall, the idea was that the pandemic inventory, unless it was specifically in the nest supplies, which were kind of not solely provincial responsibility, those would be used by filtering them through the supply chain if they were items that would be used on a regular basis. So PPE and masks would be usable during the winter months when those kind of precautions were much more common. There is a process in mind, as far as I'm aware, to write down that, so it will go to a lower level. We do need to keep some pandemic supplies in readiness, but the question is what that right sizing should be.
Okay, thank you. I'm actually getting through a lot of this stuff in those first two headings. But I got to ask, I'd be remiss if I never asked my favorite topic of nurse practitioners. I know we touch on it, but question period, sometimes you never get the real opportunity to ask. It's more frank discussion. You know, the federal government has made it possible to have nurse practitioners do billing, bill directly to government. I'm at a loss to why, and we've talked to lots of nurse practitioners out there, and to me it makes sense. It's low-hanging fruit to try to deal with their family doctor shortage, their delivery of health care, and you know all the concerns comes out with seniors having to pay fees to nurse practitioners and what have you. What is the real reason that, besides the, what's the real reason that the government isn't letting nurse practitioners bill directly to government? Forget about MCP, they can have their own billing mechanism, leave it clear of MCP, but what's the hesitation that nurse practitioners can't bill government directly?
The federal requirement, or the federal deal, was that public funds would be used to pay nurse practitioners who are in private practice. 90% of our nurse practitioners are in a salaried model in this province. We are working with the nurse practitioners group and the RNU, who are kind of their bargaining unit, to work on a way that they can access public funds if they are privately employed. It is not a fee-for-service model in the sense of you provide a specific service and you bill. It is on maybe a mode similar to Alberta. I don't want to negotiate in public, but Alberta has a system that works for nurse practitioners who are in private practice, and we've looked at that. Again, we've asked the RNU and the Nurse Practitioners Association actually to come forward with a model that they would like for nurse practitioner-led clinics, which is kind of part of the driver for this. The first time I asked the RNU, Debbie Forward was president. I still haven't heard back from them, so there must be some debate internally as to what they would like to. I'm quite happy to arrange for them in private practice to be paid out of public funds, but fee-for-service failed for physicians, so I'm not going to go down the same road again for nurse practitioners, because it will fail for them too.
I think it's something that should be explored, as we both agree to disagree, but I appreciate your remarks. Minister, the last question for this round. Cleaning the health science complex. This issue's come up again. There's another issue, and I know Dr. Parfrey's there. We've seen some alarming pictures and commentary, and quite frank with you, I've seen it myself. My sister's been there now going 3 months. She's been slowly recovering, but she's had a very serious illness, and leaves a lot to be desired. And it's something that I know I spoke about and it's been public commentary on. I know the authority or the NLHS have tried to address them, but I got to question the bigger plan. It's fine to fix that room or that floor or that 2 or 3 rooms, but you're only putting out fires. You know what I'm saying? I do believe as a whole there's a major problem somewhere in that whole operation, and it's something that I suppose it irritates me to a degree, for a good reason actually, and I think it should irritate any of us. It's not acceptable really in our main acute care hospital, but it's an issue, and it's not being addressed, in my opinion, the way it should be addressed. You can put out fires all day long, when I go on the media and then someone goes up and close off a bathroom or close off a room and fix it, you're not fixing the problem. You're putting a Band-Aid and you're putting out a fire. So I say that with all due respect for those involved, but these issues are real, and I think you can agree you see where I'm coming from. Has there been a plan, I guess, a bigger plan to deal with this issue? And I likened it at the time, I think I spoke about it, as an issue that it's like the infrastructure, preventative maintenance, or infrastructure issue at Mon. Now we're faced with being well documented. The buildings, some of the buildings are pretty hard shape. So I guess that I'm questioning the same thing happened. That's a lot of government buildings, and we're seeing it happen at the Health Science Centre. So is there any plan or planning or talks of planning in place to deal with that issue?
There is significant money for renovations for the health science site. That may or may not deal with some of the issues depending on whether they're actually directly impacted by those specific renovations. But in the process of doing that, you actually allow the repairs and reno budget to be used on those other areas. I think that, you make a good point. The challenge is we have a huge amount of infrastructure, and the Health Science Centre is now, 50 years old? And so it's an aging building. And because of that, it is sometimes difficult to walk the line between maintaining operations and having the repairs and renos done. And I think NLHS over the years has done a very good job in walking that line in such a way that services are maintained.
The member's time has expired. The member for St. John's Centre.
Thank you, Chair. How has work progressed on creating the new MCP codes required for blended capitation?
Mr. Haggie.
I can't address the exact detail of that. My understanding is that work continues, and maybe ADM Clark would be able to shed a little bit more light on that specific aspect.
Greg Clark.
Greg Clark, I'm unable to do that, but I'll certainly look into the progress on the capitation codes.
Thank you for that first section. That's it. I have one or two others from other sections, but I can wait.
Okay. Further questions? Okay, seeing no further questions, I ask the clerk to recall the subhead.
1.1.01 to 1.2.02 inclusive.
Shall 1.1.01 to 1.2.02 inclusive executive and support services carry? All those in favor? All those against? Carried. I ask the clerk to call the next subhead.
2.1.01 to 2.3.01 inclusive.
2.1.01 to 2.3.01 inclusive client services and support. Member for Conception Bay South.
Thank you, Chair. I got a few line by lines. I don't have a lot more actually, but I got a few. Under 2.1.01, prescription provincial drug programs. Under allowances and assistance, what is the nature of the extra $20 million?
Minister Haggie.
I presume the member is referring to 2025-26 less 2024. The extra 20 is related to 17.28 related to new drug therapies, 384,000 for new oncology therapies, 16 million for non-oncology therapies, and 3.1 million for new drug therapies that are coming out in 2024-25.
Thank you. Under Medicare Plan 2.2.01, physician services, under professional services, there was an extra 35 million last year, but now it's back down to the 16 million. So why was the extra 35 million, I guess, last year?
Sorry, could member read the head again, please?
2.2.01 physician services, and it's under professional services, the first.
Okay, sorry, missed you. And this is the difference between projected revised and the estimates for this year. Is that what you're asking about?
Yes, extra 35 million was actually spent.
Yeah. There's a deficit because of increased utilisation. The fee codes have increased and the activity in emergency departments has increased. So that's why we're projected with more than the budget, and we've allowed some extra in the 2025-26 based on what we think the utilisation will be next year, and a smaller amount for annualisation of drivers' medicals.
Under medical care, 2.2.02, dental services, professional services. What's the nature of the $3 million drop balance on the professional services?
Sorry, was that 2.2.02 or?
Yep.
Yep.
Dental services. On
Yep.
professional services, there was a $3 million drop balance on the revised.
Yeah, that was due to lower utilisation in the children's dental plan.
Okay. Interesting. Under 2.3.01, Memorial University Faculty of Medicine. How many seats do we have now, Minister?
84 this year. For Newfoundland and Labrador students, 84.
84, okay. And that's the Newfoundland's allotment, right? For Newfoundland
We've
students?
got one extra because an MOTP candidate from out of province dropped out, so we filled it with a Newfoundland student.
So how many Newfoundland students is there then? Did you say how many of them are Newfoundland students?
There are 82.
Newfoundland students.
Sorry, there are 84 students, and let me just check. 84. They're all Newfoundlanders.
There's 84 seats.
There's 84 seats. There's one MOTP from out of province, and then there's some from New Brunswick.
84 seats.
Deputy Minister McGrath.
There's 84 seats for Newfoundlanders and Labradorians through that.
Okay. Is that the total? Is that the total number of seats?
I think it's 85.
Okay, so it's one extra. It's okay.
That's MOT.
Yep.
It's actually
90. Yeah, there's 6.
There's 90.
Mr. Hagg.
Sorry, it's getting late. There's 84 Newfoundlanders and Labradorians. There's 90
in total.
In total,
Gotcha.
The others are a mix of out of province and MOTP.
Gotcha. Minister, on infrastructure issue. Is there any actions been taken by your department in dealing with that, or is that something that was passed over to TI?
The infrastructure related to the medical school, we simply give them a grant and a subsidy. I think the bulk of that is the bulk of their infrastructure debt is managed by education.
Well, Minister, you defer maintenance money on chairs and landscaping. Is this like this department? So is this something that's supported? Like, is this seems like we got bigger issues than landscaping and chairs.
Minister Haggie.
Could you point me to where that item appears?
AG report on infrastructure of faculty of medicine.
That was under the AG's report, Minister, on faculty of medicine. It was there's the maintenance money being deferred for use on chairs and landscaping.
Okay, I would be interested to look into that. I've not been aware of that particular issue.
That's fair enough. Yeah, well, that's all I got in this section. If we want to wait till 3, I know we're running late on time, so.
Okay, member for St. John's Centre.
Thank you, Chair. Has there been a review of the income eligibility thresholds for the provincial drug card program under the Access Plan?
Minister Haggie.
My understanding is that eligibility thresholds are actually determined by income support. I'm just making sure, though, there are 2 plans that fall outside that. Just looking for the appropriate bit. I know that outside of the department there is a cross-government review on thresholds, but I think that is across CSSD and finance.
Okay, thank you. Have any new treatments been added to the list of those covered under the NLPDP?
Yes. We have $17 million worth of new drugs, and I think there are 18 new drugs included in that.
Okay, thank you. And would it be possible to have a list? You don't have to go through them now, but have a list of what those new drugs are.
There is one. I've seen it, but it isn't in the binder.
Okay, thank you. Under 2.2.02, dental services, has rollout of the federal dental program affected funding here? And has money been reprofiled for others in need of dental care, or has money been allocated elsewhere in the department?
We haven't seen anything. There's only been the drop in the lower utilization of the children's dental plan.
Yeah.
Other than that, there's been no impact that we've seen yet.
Thank you. That's it.
That's it. Any additional questions? On section 2.1.01, no? Okay, seeing no further questions, I ask the clerk to recall the subhead.
2.1.01 to 2.3.01 inclusive.
Show 2.1.01 to 2.3.01 inclusive. Client services and support, carry. All those in favor? Aye. All those against, carry. I ask the clerk to call the next subhead.
3.1.01 to 3.2.03 inclusive.
3.1.01 to 3.2.03 inclusive, health and community service delivery. The Minister for Conception Bay South.
Thank you, Chair. Under 3.1.01, Provincial Health Authority and related services, supplies went from 6.5 budgeted to almost 11.9 million spent to now 22 million requested. Was such a variation?
Vaccines, shingles, and RSV.
Just that would have been a lot harder if you listened to me.
Sorry. Your bit's falling out. No.
I couldn't resist. 3.1.02, support to community agencies. Can we get a list of those?
Yep.
And how many groups apply and don't get anything? Because do we have a listing of those too? The unsuccessful groups that applied. Is there any people that applied and never got anything?
I would have to check. Yeah. This is the group that we fund, and in actual fact, looking at them, apart from the small grants program and unallocated funding, these are all regulars.
So it's more than likely no one got denied.
Well, I'm not aware of any.
Okay. Could you just check those?
Oh, we'll do that, certainly, and you can have the list. It's things like the Alliance for the Control of Tobacco, Canadian Red Cross, HOA, the Hub, SPAN, those kind of things, spinal injury, Association of the Deaf, these kind of things. They feature regularly.
Under 3.2.03, building improvements, furnishings and equipment. What's the reason for the increase from 176 million to 144 million, now back up to 192, so the variations? So what's the fluctuation, I should say?
That's building projects that have been paid out and been put back in again for building improvements, purchase of medical equipment, that kind of thing. The amounts fluctuate, usually because of emergent and urgent medical equipment replacements, and that's kind of our best guess for this year.
Okay. That's all the question I got in that section, Chair.
Okay. Member for St. John's Centre.
Thank you. One question. What improvements or renovations are slated to be completed this year on healthcare facilities? And which ones will be the highest priority on that list? That's under 3.2.03.
Deputy Minister McGraw.
All right, so that's a process where Newfoundland and Labrador Health Services would identify those priority pieces of equipment. It's typically block funded throughout the appropriated. So that process has started. They will submit the listing by zone, by region, and then it will go through an approval process. So I just don't have it here right now, but there is an established process by need from the Health Authority.
Perfect. Thank you. Sid?
Okay. Seeing no further questions, I ask the clerk to call the subhead.
3.1.01 to 3.2.03 inclusive.
Shall 3.1.01 to 3.2.03 inclusive carry health and community services? All those in favor? All those against? Carried.
Total.
Shall the total carry? All those in favor? All those against? Motion carried. Shall I report the estimates of the Department of Health and Community Services? Carried. All those in favor? All those against? Carried. Okay, so thank the ministers and the departmental staff and the committee for attending. The next meeting is Wednesday, April 16, 2025 at 5:30 to consider the estimates of the Department of Municipal and Provincial Affairs. I'll ask for a mover for adjournment. Member for Portgrave. All those in favor? All those against? Carried. The meeting is now adjourned.